For decades, the doctor-patient relationship relied on a straightforward contract. You explained your symptoms, and the physician used their expertise to find a cure, or at least offer relief. The interaction was rooted in mutual trust. Then the opiate epidemic triggered massive DEA crackdowns. Providers watched their peers lose medical licenses or face prison time for overprescribing, while malpractice insurance premiums increased across the industry. To manage this legal risk, hospitals built rigid, algorithm-driven protocols designed to survive a government audit. These rules prioritized institutional compliance, limiting a doctor's individual discretion in favor of standardized, risk-averse procedures. In 1971, the Stanford Prison Experiment demonstrated what happens when one group is given unchecked authority over a captive, stigmatized population. Within days, the designated authority figures began prioritizing total control and institutional order over the well-being of the subjects. This psychological framework helps explain the shift in modern chronic pain management. When the threat of liability governs every interaction, a doctor's primary role moves away from investigating complex illness and toward managing institutional risk. Under this framework, a patient presenting with difficult-to-treat pain is no longer viewed as a human being in distress. They are categorized as a potential threat to the provider's license and the hospital's financial stability. This systemic fear of liability has turned hospitals into environments focused on behavioral containment. By prioritizing the safety of the institution over the needs of the patient, the medical system effectively strips chronic pain patients of their basic human rights. A core component of the Stanford Prison Experiment was de-individuation. Researchers stripped the subjects of their names and replaced them with numbers. This psychological distance allowed the authority figures to ignore the individual's lived experiences. Modern medicine achieves this using electronic health records. A patient's complex biological history is replaced by permanent, stigmatizing labels entered into the chart, such as drug seeker or cluster B personality disorder. Automated insurance algorithms now flag patients based on simple data points. If a patient with MS sees a neurologist for nerve pain and a psychiatrist for ADHD, the algorithm tallies the different prescribers and marks the patient as a liability risk before a human ever reviews the case. This flag cascades through every connected hospital record. Before a new doctor even enters the room, they see the warning and view the patient through a lens of preemptive suspicion. Once labeled as a risk, the patient's objective physical symptoms are often ignored. We see records of patients presenting with 104-degree fevers, organ infections, or broken bones, only to be sent away without basic diagnostics. Doctors reframe these physical emergencies in the chart to fit the established narrative. Legitimate requests for pain relief or medical intervention are documented as manipulative, combative, or attention-seeking behavior. The medical chart is no longer a tool for healing. It is a weaponized document. By applying psychiatric labels to physical distress, the system creates a permanent record that erases the patient's objective physical reality. This creates the catch-22 of self-advocacy. Patients are forced into an impossible set of behavioral rules just to maintain access to basic medication and care. If a patient tries to advocate for themselves by precisely tracking their medical history, medication half-lives, and required dosages, the system uses their intelligence against them. Providers are trained to view this level of medical literacy as a sign of sophisticated addiction. Detailed knowledge of which drugs work and which cause severe side effects is used as proof of manipulation rather than a desire for safety. When a patient is flagged as high risk, providers often employ the ping-pong effect. Departments circle the wagons, avoiding direct communication and refusing to take responsibility for the patient's overall care plan. Because providing no treatment carries less legal liability than managing a complex case, doctors bounce patients between siloed specialists. No one person takes ownership, and the patient's underlying condition continues to deteriorate. Clinics cover this neglect using therapeutic buzzwords. When a patient is in agony from an untreated infection or a broken bone, providers label their distress as emotional dysregulation and tell them they simply need to use distress tolerance skills. These paradoxes leave the patient trapped in a siloed nightmare. In a system built for liability management, proving the existence of physical pain becomes a mathematical impossibility. The medical system functions exactly as its liability-focused architecture dictates. It's not failing, it's successfully protecting the institution from legal and financial exposure. This architecture has created a two-tiered standard of care. Chronic pain patients are subjected to structural gaslighting, where their physical symptoms are systematically pathologized to shield the provider from malpractice risks. The physical stakes of this dynamic are high. Patients are forced into medical deprivation, experiencing 72 hours of total sleep deprivation or untreated infections, because the institution views doing nothing as the safest legal option. Reform cannot come from within. Administrators and doctors are insulated by the same hierarchy and paperwork that caused the neglect, making internal change impossible. Standard grievance processes are designed to validate the existing record. When the chart itself is the source of the misinformation, the system simply investigates its own weaponized documentation and finds itself compliant. We need external legal frameworks that penalize medical abandonment and the falsification of records. This means creating strict penalties for using psychiatric labels to ignore objective, life-threatening physical emergencies. Until patients have the legal power to challenge their charts and hold institutions accountable for these systemic failures, the medical experiment will continue. The false reality in the record will always override the truth of the patient's pain.